Welcome my friends, this signature series of Life Conference, and this is going to be on grief counseling. This is such an important topic and so very rarely discussed in many of the webinars and conferences. Why is it so? Because nobody wants to actually get close to it. It's because it's negative. And why is it negative? It's because when a person actually suffers from infertility, you can't promise them a baby. And if a person walks into my clinic and I can tell her that, look, I'm going to give you a baby, then I actually am in place of God. So I can't be God. And that is the problem. So when a person comes into your clinic and the clinician stands there and tells them, look, don't worry, I'm here and I'm here to make you a mother. Now, what is important? That is the first mistake that most consultants do. So, to answer this question towards the end, let's begin with this topic. A person suffering from infertility will face complex issues which span biological, psychological, social, and ethical domains. Why do I say biological? Because the need for procreation is a very basic fundamental right, and this is something that has been brought through generations to say that if you do not procreate, you are incomplete, you are a bunch, and therefore they treat you like an untouchable. And this has gone whether you are educated or not educated. So that again becomes a stigma on that woman. The second thing is a psychological feeling. You go with your neighbors, you talk to them, and then you go for any of these functions, whether it is a naming ceremony or whether it's a marriage. The first thing they ask you, oh, okay, you're married for 3 years, have you any offspring? And then they say, oh, are you planning? See, the biggest problem in our society is to manage other people's problems rather than their own. So time and again, this woman keeps on getting reminded that she has to have a baby, whether she likes it or not. So most of the time it's for the psychological reason and also for the social reason, for societal reasons, that she has to have a baby just to complete that picture perfect of a woman. And of course the ethical domains. The male dominated society that we have is something that we have to actually eliminate from our mindset. And I think, my dear friends, even during this period of my lifetime, maybe a little bit of change can occur, but I do not think that we can actually eliminate this. Even though women are considered as goddesses, but believe me, in the kitchen you will still find the woman, and in the boardroom you will find the man. So even if it's a woman's domain, that there's nothing wrong with her, still you will find that when it comes to infertility, the first set of eyes and the first set of societal attention will go on the woman. At least in the 2021, we do see couples coming together, but the time when I started infertility practice, it was always the woman coming with the mother-in-law breathing down her neck, even though the husband had azoospermia, because he can actually have sex, so there can be no problem. And this was the kind of mindset for the mother. Now the aim of counseling is to explore, to understand and resolve issues arising from infertility treatment, and to clarify ways of dealing with the problem more effectively. Now what do we mean by that? When you counsel a patient, the first point is not to promise 100% success. I think we Indians are obsessed with this 0% and 100%. There is already so much of percentages that is in between that 0 and 100%. And we must realize as doctors that we are here to treat. We are not here to cure, and we are not here to promise 100%. The way we need to counsel them is to be guarded, in our response. We need to be grounded and we have to be very reasonable, and only then the expectations of the couple will also be reasonable. And this is something that I must put across to all consultants. So what is this stress? Assisted reproductive technology itself, which is a bedroom scene, is now been taken to the boardroom. So therefore, stress plays a very important role. When couples have fertility problems, both partners should be informed that stress in the male and female partner can affect couples' relationship and is likely to reduce libido and frequency of intercourse, which can contribute to the fertility problems. ART is the most stressful of all infertility treatments, and therefore one has to treat this with empathy and tell them that you are complete. It's just that we need to look at where is the source of the problem. Sometimes a simple counseling will also tell them that everything is wrong, and just giving a kind of diagnosis to say, look, you people are fine, just go ahead and try. That in itself becomes so much of a mantra for the couple, and they go back, go on a holiday, minus the mother-in-law, and voila, she is pregnant. So therefore, my dear friends, in counseling, it doesn't mean that you have to go and do IVF. So let's be clear that when you do counseling, there are different levels. Women report significantly greater infertility related anxieties than men regarding life satisfaction, sexuality, self-blame, self-esteem, and avoidance of friends. Unsuccessful treatment raises women's level of negative emotions, that is anxiety, depression, and a general distress, which continue to persist and consecutive unsuccessful cycles. What does this mean? Now you tell them when the first unsuccessful cycle, you look through those papers. There are many doctors who say, I'm sorry, you are unsuccessful, that's your fault, so therefore let's have another cycle, and that the counseling is over. And that is not the way you counsel. You have to look at the case file and find out where did we go wrong. You have to explain to the couple and say, look, this is where the whole thing went wrong, and therefore we will try and do it differently, so that the couple will feel, okay, there was something wrong, we have come a long way, we are not as ignorant as we were when we first started, so we have come a distance, and therefore we can take it forward, rather than to say it is your fault, you didn't get pregnant, I did my best, so therefore let's go into the next cycle. So she will go into the next cycle thinking that she is less of a woman, and that should not happen. We have to make her feel very comfortable and tell her that we will help her, hold her hand, be empathetic and not sympathetic. Nobody wants your charity. They all want to feel normal, and they all want to feel that things are okay. And many of these couples don't mind accepting that there is something wrong with them, but they want to know what is wrong with them, so that their expectations are also grounded, and they also want to know when to stop trying for a baby. The very big problem that I see with our consultants is they will never tell them stop trying. They'll always say try one more cycle. So it always puts them on the wrong foot. Am I just stopping at the right time when I may just get pregnant on the next cycle? Now that is something which becomes a very dangerous point, because when you say that yes, you can try, it means to say that there is hope. And when you give hope, you must be able to tell them why was it not hopeful the previous time. And people don't explain. When they first come in as new patients, there is a lot of counseling and there is a lot of talk to the patient. But at the time when the beta HCG, that is the pregnancy test, is done, it's almost the junior doctor who talks to the patient, and that is wrong. I think most of the successful IVF centers and the senior doctors who have got large practices spend more time on the unsuccessful patients rather than on the new patients. So I'm telling you, dear friends, spend more time, be there for them, lend a shoulder to cry, and then as I go through the next slides, I'll tell you how you should counsel them as well. Now, if you look at the NICE guidelines of 2013, couples who experience problems in conceiving should be seen together because both partners are affected by decisions surrounding investigations and treatment. In the days gone by, when I first started practice, I used to find that only the woman would come first because the husband would say, go and get yourself treated so that if everything is all right in you, then I will come. Because most of the time the problem is in the woman. The second thing the mother-in-law would say is that my son has no problem, you have all the problem, go to your mother's house, spend all the money, get yourself treated, get a certificate from the doctor to say you're all right, and then my son can actually come along with you. So it would be almost a year or two when the woman would be coming to the doctor without the man. So what happens is we've not actually started the treatment at all, and 1.5 years have passed. Today, thankfully, in the 20th century and the 21st century, we are finding couples coming together, which is a good thing, because when you see them together, the husband also understands that the woman is going through a problem. The husband also understands that he could have a problem, and when you see them together, they stay together, the bonding is better. So when there is a negative test for the pregnancy test, they grieve together, and this kind of togetherness brings the bonding between the couple, and the bonding between the consultant as well as the couple is that much more cemented. So if you look at people who experience fertility problems, should be informed that they may find it helpful to contact a fertility support group. Now, what is a fertility support group? A fertility support group is a group that is made up of people who have been successful in the treatment of fertility, and also people who have not been successful and have remained infertile. So when this group meets once in a month, you will find them exchange notes. And in this way, what happens is people who have gone through treatment and people who have been successful counsel people who have not been successful, and this is a great stress buster. And then what happens is this is coupled with kind of programs like yoga, or say for example you will have nutrition or obesity management. So these are general topics that are brought in. So the doctor as well as the laboratory person sit along with these people and also interact with them over tea. This breaks the barrier, and that's very, very important. We need to be talking to them so that we don't appear to be in an ivory tower. And this counseling, because fertility problems themselves and the investigations and treatment can have a lot of psychological stress. So we need to take these little bit of out of the clinic environment and talk to these patients. Counseling should be offered before, during and after investigations and treatment, irrespective of the outcome of these procedures. Now I'll tell you why. When you start with the treatment, you start with a very cautious note. I am not God. If your success rate is about 50%, then I'm going to tell you that, look ma'am, I can tell you if 10 people go through treatment, 5 people will not get pregnant. The other 5 will get pregnant. Now, I don't know in which category you will fall in. However, when I say 50%, I start with 50%, but as I go through the treatment to the time when I go through an embryo transfer, that 50% may be 80% or the 50% may come to 20%. So, we are looking at a kind of a mobile percentage when we look at the case, because we look at the quality of the egg, the quality of the follicle, we look at the quality of the egg, the embryo, and also the transfer techniques. So therefore, one has to be clear that this counseling has to go through and through from start to finish, and this counseling also has to go beyond the pregnancy test throughout the pregnancy till the baby is delivered and given to the parents, and they become proud parents, and we are very happy to participate in their happiness. That is very important. So therefore, what I would call this as integrated counseling, and this is very, very important. The second thing is, of course, counseling should be provided by someone who is not directly involved in the management of the individual and or couple's fertility problems. Why is it so? It's because this has to have an independent eye on the couple. One, it would be nice to have a nurse counselor, or it could have a person who is an MSW, a medical social worker, who deals with this kind of cases and who can actually talk to this patient, and they can actually fix the appointments at the time when they come to the doctor, and they can also have time to go and talk to the yoga teacher, the nutritionist. All these are stress busters. So when they go across and meet these people, there's a sense of a breath of fresh air, and they talk to these people. But in all cases and in all centers in tier 2 and 3 cities, you may not find qualified counselors. So therefore, the doctor doubles up into a kind of a multifaceted person, and they need to sit and do everything. So sometimes there may be a bias in which the doctor tends to get in and fit everything to what he or she is doing. So there could be a directive kind of counseling to the patients which may be harmful to the patient. When you do counseling, you have to be non-judgmental. Non-judgmental means you have to lay it on the table like a cafeteria approach. You will have to tell them that counseling, I will give you all this approach, I'll give you the pros and cons of this approach, I'll give you the success rates of this approach, time to pregnancy, and then you choose. Because since I do not have a particular procedure that will give you 100% results, then I will tell you what it is that you can choose based on what your requirements is. My job as a doctor is to give them all the choices. My job as a doctor is to say what I know best. If they choose something which is not what you know best, then you must refer them to another person who actually does better than you, and that is true counseling. Because when the person gets pregnant with the other doctor, believe me, this patient will come back to you and thank you for it, and perhaps write something nice in the social media as well. So let's look at now who is likely to need counseling. Abnormal fertility related parameters like low ovarian reserve, highly compromised semen parameters, recurrent pregnancy loss, negative IVF result, need for donor gametes, surrogacy, fertility preservation in oncology patients, those with history of psychological problems, and so this special category of people need to have special counseling, and therefore one cannot put these people in the general counseling list. The purpose of counseling here has always been better if a counselor is involved in the process. So it cannot be that the person comes right in the end when the process has already been done and the patient is crying, and then you say go to a counselor, because it's almost like getting the person when everything is already sorted out. So there's no way that the counselor can actually take her through the entire process. So right in the beginning, when you are planning on a treatment, you can put your treatment plan, and then the counselor will take it over, and they will do the psychological part and you do the procedure part. The feeling of a loss provoked by infertility reawakens past losses. Like for example, a person who's had repeated pregnancy losses, and the fact she goes through an IVF and she's going through counseling, for example, she starts thinking of all the losses she has, and she says, God, why me? Why are you punishing me? I have done nothing in this world that I have thought bad about other people. I have done nothing wrong to other people. Why are you punishing me like this? I only need one child. I just want to feel that I am a mother. I just want one child. So what happens is, when the doctor sits down and listens to this, some of the doctors just get irritated and said, oh my God, how can I be sitting down and listening to this? Let a counselor take over. See, this is where it is wrong. I think the doctor must take that white coat off and sit like a mother and talk to this patient. And this may not be all the time possible by a doctor, and therefore a counselor steps in. So that feeling of loss has to be kind of made good by this counselor. So cognitive behavioral approach might help to focus on modifying maladaptive thinking patterns. So when you get a counselor, you'll find the counselor telling them, okay, fine, things have happened in the past. We've not had genetic testing on that products of conception, for example, or things have happened so fast that we've not actually looked at the case deep enough before you got pregnant the next time. But today, don't get pregnant till we go and find out why all those losses took place. So there is a lot of thinking time, there's a lot of me time, there's a lot of our time, and so when we start going through the case, the patient feels that there is somebody to look at me, there is somebody to hold my hand, there is somebody to say that I am not sinking and you can pick me up and I can also be like everybody else. So the ultimate goal is to have a better quality life, and that is the purpose of counseling. So my objectives here would be, the first time is to enable expression of emotions. So let the person talk, you be a sounding board, which means listen. So when you listen, many times the patient is not expecting you to talk. The patient is not expecting you to answer her questions. The patient is trying to vent her emotions. So be a patient person. Don't be in a transmitting mode all the time. Don't take a pen and paper and write a prescription. Just listen to her, because all the time with all the previous doctors this has happened. So I would be very, very happy if you just sit and listen. You may even spend an hour with her without talking a word, but the fact that you've listened to her, if you observe her face, you will see that all the stress lines on her face are all easing out. There comes a slight smile at the angle of the mouth, and you'll see that the eyes will sparkle. I think if you wait enough, you will see that happen. Just try this on patients as you go back after this talk, and you'll see that these emotions will be very transparent as you see this couple. Why do we say that these people are difficult? They're not difficult. They are actually venting their frustrations. Where do they vent their frustrations? They've paid your consultation fees, then you jolly well sit and listen. Otherwise, you don't take them. But you can't say that you take the consultation fees and sit down and say, now enough, 10 minutes are over. So you keep them to the last, so that you give enough of time and sit down. The doctor may say, I am tired, my children are calling, etc. Then you know what? You should have a separate day for counseling. So you keep 1 or 2 patients and go through it. Believe me, one dissatisfied customer can send away 30 new patients from your clinic. And one satisfied customer may get you a couple of patients to your clinic. Because when patients are very satisfied, they hardly ever talk about it because infertility is a taboo. But when they are dissatisfied, they'll go all out at all social media and try and malign you. So keep this in mind. Keep a separate day for counseling. Have only 1 or 2 patients and then talk to them, because they would have had bad experiences elsewhere, and having not had an opportunity to talk to them, you may get the brunt of it. Then while they're talking, the second thing is to identify the cause of distress, and thirdly, provide intervention to minimize the distress and help better manage stress. Then how do you break the bad news? This is important. Is there any good way of breaking bad news? The team informs the patient about the results. Now, before you come to the results, as you go through the treatment, there can be indicators to say that the follicles have not come up properly, or the endometrium has not come up properly, or the hormone levels have not come up properly. So then you have enough of evidence to sort of prime them to say, look, don't expect a lot from this cycle. However, I am not going to transfer this cycle. Or I will say, I will collect these eggs, have a look at this, and if I find these eggs are not good, or I find these eggs good, but the lining is not good, I may freeze these eggs, or I may fertilize these eggs, make them into embryos and freeze them, take them into next cycle, work only on the lining and then transfer these embryos. Then the patient understands that all is not lost, and if that is not lost, then she is mentally prepared. But you can't go across and say, see, I put it in, it's your fault, if your uterus doesn't take it, what can I do? Now that is a very, very wrong way of telling this patient. Then the patient receives and understands the implications of this results. Now if you have been very soft in bringing this bad news, then her way of receiving these results is much more understandable. We need to see that she understands the implications of this result. The patient should be allowed to express their emotion and the support should be given to her. Now, complete knowledge of the causes and factors contributing to the issue should be explained to the patient. Elaboration of the options available for her in case of failed IVF, recurrent pregnancy loss and azoospermia. And in failed IVF, of course, we will have to discuss all the reasons why this failed IVF took place, like assessing the quality of the gametes, check whether any better optimization of the stimulation can be done in future, to look for donor gametes in case of poor quality gametes, and in case of the endometrium, different strategies to be tried to improve the lining. Then an entire gamut of investigations, as has been enumerated here, for recurrent pregnancy loss. And in azoospermia, of course, various retrieval techniques like teaser, peaser, teaser and microtessy can also be done. The fertility preservation has to be done before you start chemotherapy, and is very important. People come after 1 or 2 chemotherapies and then say, let me do it, and that's wrong. So you have to do it before chemotherapy, and semen freezing, oocyte freezing and embryo freezing. Now, team and patient should discuss advantages and disadvantages of each option available, and team and patient to participate in decision making. Now, stages of grief in infertility would be various mood responses like fear, anxiety, loss of self-esteem, depression, and often encountered feelings like, why am I here for? How do I define myself in this world? What do I do with my life if there is no children? And typically the first stage would be denial. Typically people respond after breaking the bad news with a shock and denial. They may take time to accept the reality of the situation. And then comes anger management. The below feelings can lead to anger, loss of a dream, loss of imagined future, loss of being unable to procreate, loss of being a biological parent, and patients may exhibit irrational behavior with staff and colleagues at work and people at the fertility clinic. This is a very complex emotion and that needs to be dealt with a very sensitive way. Bargaining happens when patient tries to exert control of the situation. Example, if I could get pregnant just once, I promise I would be the best parent ever. I only ask for one child and I will start to give my time to some charities. It is a very painful process. And then comes the depression, despair of achieving their goal. Having their own biological child leads to despair. There is an increase in the tension and anxiety. There is loss of faith, power, and a loss of dreams of the future, loss of intimacy, loss of image of being true male and female. All of them lead to depression, which needs long-term treatment. Then comes the stage of acceptance. Patient has now accepted the reality of loss, thinking of a present and to start to plan for the future. The patient is ready and various treatment options available, and they come forward. They are ready to incorporate in a different way of creating a family. They are ready to take up treatment options. The previous was unacceptable to them. Now, counseling is the most important technique in IVF practice, both for the patient and doctor. and motivating and staying positive throughout the journey is also very important. So, my dear friends, there is always hope at the end of the tunnel, and integration throughout the entire process of infertility management is the only way that you can keep not only the patients positive but also the doctors positive. Thank you very much.